Because nothing that we teach only as a theory is going to have a lasting effect. We teach it as a theory and a laboratory experience. The laboratory experience for the learning of this vital theory is doing psychotherapy during resident education. And we provide this experience in psychotherapy with, we hope, adequately trained supervisors so that the resident may experience how the patient experiences himself over time with an illness, how the patient constructs his past, present, and future in relation to the illness that the patient has. That illness may be a mental illness of the major disorders. That illness may be a physical illness. That illness may be a characterologic difficulty. In any of those events, what the resident must begin to understand is how it is that the patient will put together that story and how various ways of putting together that story will assist the patient's adaptation to the world or hinder his adaptation. That laboratory experience of understanding the patient over time is vital for our residents to begin to understand the theory that Dr. McHugh concedes is one of the vital theories for a resident to learn in the 1980s. The imperialist claims of the 50s are long gone. That's not the topic of today's debate. We have an interesting other reason today for making psychodynamic theory and therapy a vital part of education for the resident, and that is we now do have highly effective medications and organic treatments for some of the major mental disorders. That creates interesting new opportunities because one of the problems, as everyone in this audience knows, is that patients don't readily comply with these medications. These medications all have terribly undesirable side effects, even in small doses, and we now have excellent studies that if we wish our patients to take the medicines, that requires that we understand what the medicine means to the patient, that we understand the relationship of the patient to the doctor who's prescribing, that we help the patient to understand that there will be a continuing relationship. That brings me to another aspect of what it is we're teaching in this central core, a central core of education. We're teaching about the doctor-patient relationship. One of the striking things about Dr. McHugh's book, excellent in so many respects, is that if one turns to the index, 3 interesting topics are not listed there. He doesn't mention unconscious in the index, though it is in the text, and he doesn't mention transference and countertransference. It's difficult for me to understand how any modern psychiatrist can hope to keep contact with his patient over time and help his patient surmount the extraordinary difficulties of coping with the consequences of loss, the consequences of perhaps a lifetime of affective dysregulation, the consequences of dealing with a biological substrate that has been abnormal from the start, how that can be done without understanding how that patient is going to relate not only to the illness, but to the doctor, and how the doctor is going to relate to the patient. If I may take one more minute, I'm going to read you another quote of many quotes I could read. This is from a paper I'm sure that most of you have seen. It's called Can We Talk? The Schizophrenic Patient in Psychotherapy, written by a recovering patient, published in the American Journal of Psychiatry a while ago. And this patient describes in great detail how efforts at supportive psychotherapy were insufficient for her. They didn't really help while she was on her medication. And what she needed was the need for establishing an affective relationship with her therapist. And she says, during times when I am able to recognize this need for closeness, yet remain afraid of it, pushing people away while perceiving them as rejecting me, I struggle with incredible pain. It is not an easily resolved dilemma. Either way, the schizophrenic patient must withstand intolerable suffering, but it seems that only through psychotherapy can the world of unreality truly be dispelled. There are those bad days, but I must admit there are other days when I'm glad that they, referring to her psychotherapist, did not give up on me, and there's someone standing beside me, guiding me to the knowledge of another existence. My point is that it is especially now, when we are able to provide assistance to terribly sick patients, that being able to provide the additional assistance that comes from a genuine psychodynamic understanding of what a patient's experience and an understanding of how patients must use doctors and of the difficulties that we will have in maintaining contact with these very sick patients. This is a core of residency training now and for the foreseeable future. Thank you.
Thank you. We've had the initial presentations. The next segment of our debate is a 15-minute period during which we have a chance to let the presenters rebut what's been said by the other team and to sort of put each other on the grill. We've been altogether too friendly so far, and I hope that this will liven things up. Someone from the affirmative team have the first question to someone on the negative team.
Is this to be done in question and answer form, Dr. Boris, yes, or is it to be done in rebuttal form with a few comments on those very generous remarks by our... My friends say it's better that I rebut a little. And I'm going to just rebut a little bit, if only to make it clear that this is not just an argument over the article A or the. That's not, it's not just it is an argument over central on the one hand, and what central means. And central means something different from important. And our idea on our side has been psychodynamic teaching is important, but its problem is it always tries to be central. Secondly, to come to some of the issues, though, that were made by our opponents, just to make it clear why we are disagreeing, because we are disagreeing to a certain extent, and the hope is through several of these sessions that our disagreements will at least be either put to rest or agreed upon so we don't have to discuss them anymore. But the vital and different disagreement is over just what the role, what is the fundamental method behind the psychodynamic idea. You see, I believe that psychiatry has not just emerged into a new era where we have diverse opinions and where we have different tools. We are in a new era where we look at what we teach, at the grammar of what we teach, at the generative logics of what we teach, and where their authority rises from. That's what we have to teach our residents, so that they do not think that we are just giving them tools to apply like nickel in the slot therapists, but rather that we are engaging them in an understanding of the methods on which their authority and programs rest. And it is my point that the ideas of psychotherapy the ideas of psychodynamics, rather, are not of the same sort as data, observations of data, interpretations, theories, and laws that eventually come to be tested by the hypothetical deductive method of science. Rather, this is truly the narrative method, a method in which we see and empathize with the development of a set of events over time and lead to an understanding of an outcome. I am saying that that's important. We human beings are selves. You've got to teach them about selves. But you also have to teach in the process that this method is very vulnerable to a number of issues. They are vulnerable, for example, to the herd instinct in which we begin to think only one way about human nature. It's also vulnerable to this Gnostic sectarian I know it and you don't know the secret behind human nature, which is built into all story methods and leads to interpretive communities that fight with one another. Dr. Cooper seemed to say that all is sunshine and light amongst the psychodynamicists. That might be in New York, but it sure is in other places where they fight over what I think are just different interpretations of the story. Finally, the issue of the story is not that it produces a law at the end. And it won't. Its further elaboration and its so-called systematization will not do that. What it produces are maxims. Maxims that are enlightening, maxims that are illuminating, but just maxims that in which opposites are equally true and in which there is no resolution often as a generalization as to whether that is a good or a not so good interpretation of all of human nature or even of this clinical problem. Fundamentally, the difficulty comes that we see and appreciate a good therapist and don't know whether that comes from the maxims that he preaches or due to his own, like Dr. Havens and Dr. Cooper's, great skills as people. Thank you very much.
Which of the members of the negative team want to respond first?
I think that helps a little bit. I think we begin to see that the problem that Dr. McHugh has with this psychiatry business is that it is psychic and it's psychological. That it isn't merely biological, or not merely, but it isn't merely physical and neurological, but that it's psychological. And the nature of the psychological is, as he says, a very contested matter. I should say to you, as Dr. Cooper just said a moment ago, the nature of the biological in psychiatry is also a contested matter. There being no settled theories either about our brain biology. But let me put that aside, because hopefully some clarity can be found there. But I really think the problem Dr. McHugh has is with psychiatry. And I don't blame him for that. I don't even expect to be able to help him very much with it. But I do worry that those of you who take him seriously, and I take him seriously too, this book he wrote, The Perspectives on Psychiatry, is a very serious effort to understand the philosophical bases of the different psychiatric schools. It owes a great deal to Carl Jaspers's marvelous book, The General Psychopathology, in which the distinction between causes and understandings, between Erklären and Verstehen, was put forward in the great tradition of German academic life. And those are powerful arguments. And there are real questions about the nature of psychological evidence and how one determines it, proves it in a scientific sense, and those will probably remain with us. But don't let us be deceived by the complexities and difficulties of evaluating psychological evidence. Don't let us be deceived into thinking that that isn't what our business is about, because it is. And one of the triumphant aspects of modern psychiatry has been this steady, critical and self-critical tackling of this whole issue of what are psychological and sociological phenomena and how can they be critically approached. And although many among us, and I think Dr. McHugh is one, that would like to put this on the back burner, whether we call that important rather than central, or provincial rather than imperial, or whatever terms we take, there is this hope that these extraordinarily interesting psychological phenomena can somehow be washed out of the center of psychiatry. And then we can all go back to being medical students again and thinking about the separate parts of the human body and forgetting about these extraordinary human psychological concerns. I don't think that will happen. I hope it doesn't, because I think the rest of medicine might like to swallow us into neurology or internal medicine. But I don't think there's any chance at all that the name of our field is going to change. and that we will stop being psychiatrists. You remember once we were called mind doctors. That was the first name we had. Wasn't a bad one. Then we were called alienists. Then we were going to be called psychopathological specialists for a long time. And that strange butterfly term psychiatrist went out. Hope we keep it, because it has that syllable at the start. Thank you.
We have about 6 minutes left in this portion. Dr. Stein, if you can give us 3 and save 3 for Dr. Cooper.
You fellas got all the water.
Sit down, Leston. I'm puzzled why you're so worried about psychiatry. There's no question about the future of psychiatry other than in your mind. In some way, sitting here, I feel as though I'm a member of the other team. The way they're ganging up on my distinguished colleague here, Paul McHugh. It's been a long while since I've been told I could not read. I think it was the 3rd grade, Arnie. It troubled me then, and it troubles me again this morning. I think I can read quite well. And in fact, the term central is the issue. That is the only issue. And I was concerned that that might become an issue, because in reading the resolution, the 2 terms, need be and central, I think caused the major confusion. So I checked in terms of Webster what central is. It's at the center. I don't know how many things you can have at the center. At the center is at the center. There is no question, and even to use your term, Dr. Cooper, that psychodynamics is a vital part, no argument about that. But to say it is the center of training, there is a good deal of argument about that. Even in your own discussions, you switched back and forth between a central and the central, and caught yourself on one occasion. My psychoanalytic background.
All is not lost.
Far from it. Far from it. Now, I think that if we're going to say, is there something at the center, what should be at the center? What might we consider at the center? And from my point of view, I think the center is to prepare the psychiatrists of the future for the future. I don't think there is anyone in this room who can predict what the psychiatry of the future is going to be 10 to 15 or maybe even 5 years down the road. Certainly in my career, I would have never predicted, say 40 years ago, the changes. I think that is also true of all of medicine. Now this gets back to, thank you. This gets back to, I think, Dr. Haven's concern about psychiatry, if it's going to exist. Certainly psychiatry will exist. I think that's not Paul's not being satisfied or comfortable with psychologic or psychiatry. I think Dr. Havens has a difficult time with a scientific medicine. Thank you.
Dr. Cooper, I'm sure you have something to say to that.
The last thing I wanted to do was further traumatize Dr. Stein over reading problems. But I think there is a long-standing trauma that has taken the stage here and ought not. And that's the trauma that some people went through during a phase in which psychodynamics was the center of psychiatry, and it wasn't all that bad. There was nothing else to do at that time, and so it took the center. Psychodynamics has, I think, now adopted its proper role, not without struggling within psychodynamics. And I think that Dr. Stein and Dr. McHugh might be agreeable to the idea that the psychiatry of the future will not have one center. It is clearly a multi-centered field. We are in a field with many dimensions, so there is room for centers, not just a center, for centers of interest and focus and education, and psychodynamics will be one of them. I think that what we're talking about is the ways in which we will continue to maintain our focus on the psychological life of our patients during the future, and I agree, we cannot predict the future. All the more important, therefore, that we keep alive what is, in fact, a rather good method for understanding how it is that our patients function psychologically. The question of whether we are science when we're talking about life story and psychodynamics. The life story as narrative alone, and as perhaps was put forth by Adolf Meyer, is probably hermeneutic and not subject to science. The life story as intended in the psychodynamic method can be, at least in aspects, and I don't want to exaggerate this, subject to scientific study. The issue of unconscious, the dynamic unconscious, originally regarded as mythology. Today, I think psychiatrists generally would accept that it's an experience near matter, that we can make good demonstrations that patients don't always say what they mean and that they mean things they cannot say. Dr. Stein correctly picks me up on a parapraxis. A friend of mine who's a teacher of English literature says he gave up lecturing on Mark Twain because whenever he was lecturing on him, he would have to give a lecture on Huck Finn, and he couldn't do it without making a parapraxis. We understand those parapraxes. The fact that psychodynamics has not yet given itself over to adequate scientific study is of great interest to those of us who are concerned with it, and I think that will be a matter for one of the futures of psychiatry. So we will continue then to help our residents to understand how it is that they will interact with their patients and how it is that they will learn to use themselves as perhaps the most accurate meter we yet have for knowing what it is that their patients are experiencing, for being able to detect the patient's intentions before the patient always knows what his intention is, but has revealed it through the sensitive barometer of the doctor's responsiveness to the patient. This is a core of psychiatric education.
Thank you. We now have 15 minutes for your very active participation. There are certain ground rules for this as well. We'd like you to stand, identify yourself, and ask a brief question limited to 1 minute or less. This is not a time to join in the debate, but to ask specific questions of any of the debaters. Who wants to lead off? Please stand and identify yourself.
I'm surprised in this debate to not hear what seems to me to be a greater challenge than biological challenge to the centrality of psychodynamic teaching, and that's the development of alternative effective psychotherapy. In a very brief number of years, cognitive and behavioral therapy has demonstrated their effectiveness to a much greater extent than psychodynamic psychotherapy has over a rather much lengthier time that it could have been and has been studied. It seems to me that these therapies that seek for validation offer something, Dr. McHugh's paradigm of looking for bringing empirical evidence into and of usefulness into psychiatry. So we're faced perhaps with a treatment, dynamic treatment that has important, meaningful experiences for patients that may have an aspect of historiography rather than a focus on treatment.
Your question, Dr. Reeder.
I'm interested in whether psychodynamic therapy can keep their central focus in patient appreciation of the usefulness of cognitive therapy, and whether the psychodynamicists will fact, incorporating into their psychoanalytic courses on cognitive theory.
We get one respondent from each side. Briefly, please.
I thought they were going to ask us that too.
Answer the question, Leston.
I don't, well, we won't go into their reading or writing difficulties any further. I think that's a very important question, and I'm eager to answer it. I don't mean to imply at all that the only psychological methods are ones that are rooted in psychoanalysis. I think, however, the term psychodynamic is sufficiently flexible here so that we've left that question somewhat up in the air. But if you look at, say, cognitive therapy closely in its aspects, you will see that it is not separated in the way that question suggests so sharply from the general mainstream history of psychodynamic psychiatry. Indeed, if you read Beck's account of the origin of that work, you will see how much it is an offshoot of many aspects of psychodynamic work. But this is only to welcome these changes and not to try to co-opt them for every aspect of psychodynamics. The question of behaviorism is a much more complex one. I've spent a long time following the behaviorist psychotherapeutic literature, and it's a very complex one, and it would be a mistake, and I'm sure Ron knows it as well as anyone, to simply say it was against psychodynamics. Because one of the most interesting developments in modern behaviorist methods is the way in which they have made use of psychodynamic insights and cultivated them in behaviorist ways. Saying as Franz Alexander's old friend, what was his name back in Chicago? French did, that indeed both psychodynamics and behaviorism could be translated back and forth into each other. And that is increasingly a development in behaviorist work now on the practical level of psychotherapy. Thank you.
Someone from the other team want to speak to this issue?
Yeah.
We didn't discuss that, Dr. Rita, primarily because we didn't think that psychotherapy was our primary focus of discussion. We certainly agree with you. We agree with you, in fact, at this level, that we think, in contrast to our antagonists, that we are not talking about the biological, psychological difference, that we are talking about the differences between maxims and empirical evidence in the psychological as well as in the biological realm. And therefore, any evidence that can be put in an empirical way and developed according to a hypothetical deductive method and shown for its effectiveness is the important grist for our mill. Thank you.
Thank you. Next question. Sir.
Dr. Parris from McGill. I came in inclined for the negative, but I thought Dr. McHugh won the debate by knockout in the first round. And I think that the reason is because I think you addressed the question of epistemology, which is so important for the future of psychiatry. Why is it that psychodynamic psychiatry has ceased to be creative and has ceased to develop new ideas? It seems to me what's happened is they back themselves into an epistemological corner by saying we're hermeneuticists.
Your question, Dr. Parris.
Well, the question is really for the negative side. Can they demonstrate that psychodynamic psychiatry is not just a tradition which we're passing on from generation to generation, and that it's valuable, which I don't disagree with, but that it's going to create something new in the future?
Repeat the question for them. Tell them what the question is.
The question, if I understood it correctly, was why is it that psychodynamics produces nothing new and has not become a part of modern epistemology and is simply a repetition of old maxims? Is that a correct statement of the question? And I'm delighted to have the question, because it seems to me that precisely what has happened in the field of psychodynamics during the past 15 years is that we've gotten out of an area of stultification and dogma, and that the true scientific route of psychodynamics, which Freud was well aware of and which Dr. McHugh quoted, the biological as well as the historiographic and hermeneutic roots are now much in the fore, and what's going on at the present time in psychodynamics is an entirely different era of competing theories, competing very hard, competing quite ferociously, of all of science competes with its theories, and the beginnings of attempts to test. Weiss and Sampson have recently written what I think is a fascinating book demonstrating an attempt to validate one version of psychodynamic theory, a false belief set of psychodynamic theories, and it relates to the previous question, how does one deal with cognitive theory within psychodynamics? I recommend Weiss and Sampson's work to you. Luborsky has made other attempts, others are making other attempts to validate aspects of psychodynamic points of view and psychodynamic theories. It's very difficult work to do, but it is being done, and what's most significant is that these debates are going on now, beginning to go on at a level not simply of the clinical vignette, which has been the tradition, as McHugh correctly points out, but now for the first time beginning to develop a sophistication of how to research this. I should point out that psychodynamics, unlike biochemistry, psychodynamics is less than 100 years old. The tradition of research is very poor in the field of psychodynamics, only just beginning, and I am very hopeful that it will be a powerful tradition for the future. Well, let me stop at that point.
Anyone from the affirmative team want to speak to that issue? Okay. Next question. Dr. Meyerson.
Mark Meyerson from Philadelphia. I'd like to go to a more operationalized definition of core. After all, when we define core, we generally do so in terms of time and stress, not as all members of the debate have done, which is simply to accept the value, ill-defined, of psychodynamic psychiatry. Given, I'll turn it into a question, given 2 million schizophrenics, given 5 to 10 million manic depressives, given 8% of the population alcoholics, given 5% of people over 65 with Alzheimer's disease, and add other dimensions and drug abuse, given all that, given the need to diagnose properly, to manage biologics, to involve ourselves in teaching modern investigative techniques to residents, which is what we're talking about, how much time and stress does each side of this debate feel is left for properly psychodynamic psychiatry?
One member of each team, I think, might say something.
We were starting with the negative. Why don't you start with this with the affirmative? Do you want
The question is how much time and emphasis should be given to training in psychodynamics when there are so many other psychiatrically ill people and problems?
Well, as you'll recall, in my more formal presentation, I said I could discuss that and did not want to. I really still do not want to get involved in that because it becomes a numbers game. And I think it's a complicated issue. We're not here to really develop a core curriculum of residency training. And I don't think that Art Meyerson's question was intended to develop such a core. The question is, though, how much weight will you give to psychodynamics? The question really has to be, I think, phrased in a different form, and that given all that we must teach within 3 years of training, and given what we now know, and not that we're just beginning to get some science in psychodynamics, Dr. Cooper, given that, then I think we have to put it in the perspective of that it's important, but it is not a central part of the core. And given that amount of time in terms of what we would consider in terms of prioritizing, I'll not make that priority list at this point, but it certainly does not head the list.
Dr. Havens.
One of the things that has impressed me most in the 35 years I've spent in the state hospital system, in this case in Massachusetts, one of the things that has impressed me the most in a clinical lifetime devoted to psychotic people, to addicts, and to problems and severe character disorders of many kinds, is that the patients themselves have not changed very much. That the clinical day-to-day situations in our hospitals are very similar as they were 30 years ago, with the exception that we are better able to manage acute situations, and violent situations are much better managed. But what we have today in our hospitals and our outpatient departments, in the very large populations that have been asked about here, are very close to being chronic characterological problems of psychotic or near-psychotic nature. And their management is one of the 2 or 3 central foci of the future of psychiatry, in my opinion. And when we talk about manic depressive or schizophrenic, we should talk about them for the most part in some element of remission, where we then deal with them as characterological problems. So this whole debate could turn around what we guess, and it's only a guess, God knows, because let's hope some of these problems will be taken away from us in a summary fashion by some discovery or other. But let us try to guess what it is we are going to need to manage these long-term characterological problems, including the homeless. Now, the diagnosis and medication of these cases is certainly a good part of that, but it is by no means the only part, and even, in my opinion, the part most difficult to learn. I think the most difficult part of this problem to learn and to teach to those teams that we have to lead in the management of these characterological problems. The most difficult part is one, I don't mean exclusively related to psychodynamics, but the broad concern with sociological management techniques, which certainly includes a very central place in psychodynamic work. I personally believe that that's the central challenge of psychiatry in the next 20 years, much as that's guesswork. But as we train our young people, or as we try to prepare our young people for that task, I think the answer is unequivocally yes, that we need a very central place in the psychological understanding of these characterological problems, which for the most part, the biological and other studies have not yet illuminated. Thank you.
We unfortunately only have 20 minutes left, and according to our format, those would be to be devoted to 2 10-minute closing arguments by one member of each team. Since the affirmative team led off in the beginning of the debate, the negative team is asked to present a 10-minute closing argument to try and bring all of their opinions and the differences between theirs and the other teams into perspective. Who's going to speak for you all? Dr. Cooper.
I want to leave you with the idea that psychodynamic theory and psychodynamic therapy are a part of the central core of residency education because they are at the heart of what psychiatrists always have done and always will be doing as far as we can tell a future for psychiatry. They are the core of how we go about learning to talk to and interact with our patients. And as Dr. Havens just pointed out to you, that's not going to change as we begin to develop more effective biological medicines, I'm not going to call them cures, biological adjuvants for the management of our very sick patients. That's going to be even more the case because those patients then, as I read to you from that schizophrenic patient, will be able to benefit from the understanding that psychodynamics can bring. Psychodynamics is not just a question of a humanities-based idea in psychiatry or medicine. Psychodynamics is a highly coordinated, systematic set of ideas about how the mind operates. The arguments that go on among psychoanalysts and psychodynamicists relate to the details, as is the case in every other field of medicine. But there is a large area of general agreement concerning the role of unconscious mental functioning, concerning the role of the early period of growth and development on later events, concerning the role of traumas, both past and present, in the development of current adaptation. Those kinds of things are learnable. They have a theory behind them, not all of it scientifically tested, but a good deal of it now being able to be subject to scientific test. And one of the best tests of a scientific theory is not only whether it has been validated, because as I think most people would now agree, a positivist, Popperian view of science is rather outmoded. We look to other things from our scientific theories. One of the best tests is, does it lead to interesting new areas of investigation, observation that would not have occurred? And psychodynamic theory has led to many of the important areas of current investigation. I will point primarily to the area of infant investigation, a lively, productive field which has now produced many of the significant findings that have changed our view of what babies are about and how the beginnings of mental life begin to influence later developmental events. Therefore, the residents who are being trained today will learn not only all of the wonderful new things that they're learning about biological psychiatry, but they will approach them with an understanding of how human beings operate in their mental life. They will begin to be able to have a new kind of synthesis that I think none of us on this platform has yet fully achieved. I begin to notice in our residents today that they don't see the struggle that we're debating today. They don't have a difficulty in beginning to devise a career of entering research in biological psychiatry while keeping on their long-term psychotherapy patients and getting supervision, and debating whether they should get analytic training if they could possibly squeeze it in, because they believe that analytic training would be a great assistance to them in understanding the fine points of the mental lives of the patients whose biological illnesses they are interested in. After all, the interest in the brain is not because of the brain itself. We're interested in the brain because of what it tells us about how people are functioning in their thoughtful, affective lives. And psychodynamic theory is still the best, most comprehensive, most intriguing, most productive theory for understanding how it is that people lead their psychological, mental lives, many of which are highly disordered. The question of whether we can devote time to this in a residency training program seems to me a non-question, because this is, again, not central, but a central core for whatever is going to happen for the future of psychiatry. On a recent visit to China, where I visited a whole series of Chinese psychiatric hospitals where they are devoting their resources almost exclusively to the treatment of the severely mentally ill. And I asked the question, what do you do about psychodynamics and what do you do about these people after you get them out of the hospital? And the answer was, well, we don't yet have the resources to give to that, but we're developing it. And in fact, they now have begun to open psychotherapy clinics based on Freudian psychodynamic principles. In a lecture I gave at Beijing University, the students there were terribly interested in how they can begin to bring to China Freudian psychodynamics, and somebody's doing a translation of the complete works of Freud. My point being that if the Chinese recognize the need, and every Chinese who gets to know that you're a psychiatrist will begin to tell you about the difficulties of his depression and his sexual difficulties, etc., to whom there's no one to speak in China. If the Chinese can begin to devote resources to that, it's unthinkable that we shouldn't have a central place for what is a central problem of living not only for the severely mentally ill, but also for that large number of people characterologically disordered, and as we begin to learn, characterologically disordered not only because of past traumas, but probably because of intrinsic biological dysregulations in many cases. But that understanding of the relationship of remote trauma, biological dysregulation, current defensive functioning, the ways in which one establishes relationships not only with peers, with one's loved ones, but also with the doctors who will take care of them. That understanding is vitally dependent on a core understanding of dynamic theory and an experience with it which makes that theory alive. That experience will be obtainable only by the continuing experience with psychotherapy. Whether the doctors of the future will do psychotherapy primarily is not the interest of this debate. The interest of this debate is, must they know enough about psychotherapy so that they will understand their patients and how to react to them? I'll give you one more clinical instance. At our hospital, we run something called the Tuesday Clinic. What it really is a medication clinic, and it has continuing problems. What are the problems? The problems in that clinic are that we assign psychopharmacologists as their supervisors, and they provide superb psychopharmacologic supervision. But the residents in that clinic report that in order to retain the patients in the clinic, in order to keep those patients functioning well, they're spending their time not adjusting their medications primarily, but talking to the patients about the dynamic issues that arise not only around the medication, but about the stresses that continue whenever one is living with a major disorder which is not completely cured, and we have no sight of that for the future, not completely cured by an organic treatment. Therefore, to leave this out of residency training, psychodynamic theory, and therapy as its laboratory, to leave this out seems to me unthinkable. I'm sure it won't happen, and I have evidence that those programs that don't have psychodynamics as part of that core, which occurred about 5 years ago, are now looking to reinstitute it. And I'm pleased to know, as Dr. McHugh informs us, that he has always had psychodynamics as a core of his training programs, and I'm sure he'll continue to. Thank you.